Hello, I'm Dr. Mira Irons, President and CEO of the College of Physicians of Philadelphia. Welcome to the latest in our series, College Conversations, Medicine, Science, and Society. Today, I'm speaking with Dr. Paul Offit, Director of the Vaccine Education Center and Professor of Pediatrics in the Division of Infectious Diseases at the Children's Hospital of Philadelphia, as well as a fellow and member of the Board of Trustees of the college. Paul, it seems as though we continue to be in a world of every day is a new adventure with COVID, specifically in the sense that people have to intentionally continue to make decisions about life, where to go, whether to mask or not, what symptoms are concerning, what vaccine to get. You've always been able to provide clarity and information that helps us all make informed choices. And before we start, I just want to thank you for that.
My pleasure.
So to start with the newest information we have, the FDA and the CDC have recently authorized COVID vaccines for children 6 months and older. How should parents think about vaccinating their youngest children for COVID? What do they need to know regarding side effects that infants and toddlers might have? And also, for some who might be able to choose between a Pfizer and a Moderna vaccine, how do they decide between one and the other?
Right. So I think the first issue is this an important disease in children, in young children? Certainly, we know that 80% of the deaths are in people over 65 years of age. 93% of the deaths are in people over 55 years of age. And I think many parents have the notion that this really isn't a big deal for children, COVID, but that's wrong. With the data that were presented by the CDC to the FDA Vaccine Advisory Committee, on which I sit about a week or so ago, stated that over the last 2 years, about 45,000 children less than 5 years of age have been hospitalized with COVID. About 10,000 of those children who were hospitalized had to be admitted to the intensive care unit. And about 440 children less than 5 years of age have died from this virus. That's certainly the same, if not more, than a lot of the other viruses for which we have vaccines for young children. So is it worth preventing this disease? Yes. Now, it may be that as we have a much higher level of population immunity now than we did obviously 2 years ago, that this will be less of an issue for children. But the issue is the vaccine safe? Because if the vaccine is safe, then the benefits clearly outweigh the risks. So the issue is it's safe. And I think the answer is yes. I mean, we have a wealth of information on mRNA vaccines in people over 5 years of age, the 5 to 11-year-old. Now, millions of children in the US and the world have been vaccinated at 5 to 11 years of age. Certainly, the vaccine can cause side effects like fever, headache, fatigue, joint ache, muscle ache, but those are just side effects of having an immune response and can be found with most vaccines. The side effect you worry about is myocarditis or inflammation of the heart muscle, because that was seen in about 1 in 5,000 people between, say, 16 and 17 years of age. So rare but real. So we worried as you got to younger age groups that myocarditis would be even more common. As it turns out, it was less common. When you look at the 12 to 15-year-old age group, although it can occur, it's actually quite rare. And for the 5 to 11-year-old age group, it's even rarer. And remember, this virus, SARS-CoV-2, the virus that causes COVID, can also cause myocarditis. If you look at a disease called MIS-C, which is this multi-system inflammatory disease, where basically the child develops an autoimmune response directed against their heart, their liver, their kidneys. It's a pretty serious illness. About half to 3/4 of those children who have MIS-C will have myocarditis. So again, this is a disease worth preventing. We have 2 vaccines out there now, Moderna and Pfizer's vaccine. They are different. I mean, if you look sort of historically, starting from when a year and a half ago, when we first advised that the Moderna vaccines could be given for adults, and then a year ago, when we agreed that it could be given to those 12 to 15 years of age, and 6 months ago, 7 months ago, when we agreed it could be given to children 5 to 11, those 2 vaccines always track the same. The Moderna and Pfizer's vaccines were always very similar. They're not as similar here for the less than 5-year-old. Moderna's is a 2-dose vaccine, Pfizer's is a 3-dose vaccine. That's the biggest difference. So Moderna, 2 doses, 1 month apart. Pfizer, 3 doses, the second dose 3 weeks after the first, the third dose at least 2 months after the second. So you could argue, if that's true, if you only get protection against a serious illness after the third dose, then you really have to wait 14 weeks from dose 1 to be protected with Pfizer's vaccine, but you have to wait only 6 weeks from dose 1 to be protected with Moderna's vaccine. I also actually believe that in the end, Moderna's vaccine will also be a 3-dose vaccine. The company is in the midst of doing trials. They said that they will be finished those trials by July. So I think in the end, they're both going to be 3-dose vaccines. My attitude on this is get what you can.
Okay. All right. I don't remember a time with other vaccines that parents had to consciously choose between one or the other. You went to your pediatrician or you went to your health department, you got whatever vaccine they had, right? And now there are, conversations going on about this. So this is really helpful. Moving on to boosters. The first booster is now authorized and recommended for vaccinated children 5 and older. What would you advise parents about when to take their child in for a booster and why?
This has been a confusing subject, to
Yeah.
say the least. I think if you ask Americans, what does it mean to be fully vaccinated? You'd get a lot of different answers because I think it has been confusing. If you look, for example, when these vaccines first rolled out in December of 2020, the predominant strains initially was the first strain that came out of Wuhan, which didn't have a Greek letter designation. It was called the D614G strain. That was replaced by the Alpha variant, which was replaced by the Delta variant, all because each successive variant was more contagious. But each of those variants was highly susceptible to vaccination with what essentially was the original strain. I mean, the vaccine that we use is the so-called ancestral strain vaccine. That was the original Wuhan strain. But it protected well, even against mild disease, for each of these different variants. So if you look at the data that were actually just recently published by the CDC, if you look through, say, March of December of 2021, last year, did 2 doses of vaccines protect for that 9-month period of time well against serious illness? Yes. You only needed 2 doses for protection against serious disease with Delta. And that was for everybody over 18, including many people over 65, including many people with comorbidities. So 2 doses was enough. So I was always of the belief that 2 doses was enough until Omicron. Omicron crossed the line, and now the Omicron subvariants, BA4, BA5, BA2. Where that crossed the line is that when you look at, for example, the D614G variant, which essentially had 1 critical mutation, and then the Alpha and the Delta variants, which have a handful of critical mutations that made them more contagious, but not more resistant to immunity induced by vaccination. That changed with Omicron. Omicron has 30 mutations in the receptor binding domain, and so it is an immune evasive strain. Think of it in the same way you think of influenza as a drifted virus. So now you were really not protected as well against mild illness at all, really. I mean, when Tony Fauci gets a mild illness
Right.
after getting 4 doses of vaccine and wearing a mask all the time, it tells you we're dealing with these Omicron subvariant strains that are highly contagious and immune evasive, but not immune evasive against serious disease. But in any case, with all this now infection, even in people who are vaccinated, that's where the 3rd dose recommendation was born. I would argue that the advantage of a 3rd dose is that it increases your neutralizing antibodies for 3 to 6 months. It will protect you against then mild disease for 3 to 6 months. Now, for some people who are immune compromised or elderly or have multiple comorbidities, obviously an additional dose is of value. But I think that the right way to think about this is that for some people, this is a 3-dose primary series. So forget the word booster. People who are elderly, people who are immune compromised, it's at least a 3-dose primary series. For the booster dose, again, we'll offer protection against mild disease for 3 to 6 months. And that's it. I mean, so I'm over 65. Since this is, you can see me on the screen, I'm over 65. I never got a 4th dose. I felt that 3 doses protected me against serious disease. And about a month ago, I had a mild COVID illness, which sort of validated my notion that I was protected against serious disease. But it lasted for a day or 2. I never took Paxlovid because even though my 3rd dose was a year ago, I was still protected against serious disease. So that's the information we really need going forward. The CDC can help us out here more than they have, frankly, to date, is let's look at those people who are, let's say, less than 65 and otherwise healthy, people who are over 65 and otherwise healthy, and see for how long do memory cells last to protect you against serious disease. Do you really need booster doses? And if so, who gets them and what are we going to be getting them with? So it's so confusing. You have like 2 doses is fully vaccinated, 3rd dose is up to date. It's just really confusing. But I would say this. If you're otherwise healthy and you've gotten 3 doses of vaccine, I think you're protected against serious disease probably for a while. I mean, I would imagine a few years. Time will tell. We'll see.
Okay, that's interesting because, my next question is obviously going to be that 4th dose. And, I think that the immunocompromised people, moderately and severely, that's a group that, is taken care of, right? It's this issue of the 4th dose being recommended for people 50 and above. And there are now, you're getting texts from your local health department saying you should come in for a 4th dose. There are signs on roadways. telling people they should get a fourth dose. So I think that there is this confusion out there in terms of, should you get a fourth dose, should you not get a fourth dose? But I guess, you just answered that question. It's unclear when you should get that fourth dose.
Everything comes out of Israel, a country that is on the other side of the world, that's 1/30 our size, has a different sort of age stratification, and certainly a different ethnic makeup. Nonetheless, it's Israel that we look to. And I think if you look at that fourth dose data, they're pretty weak. I think if that had come to our committee, the FDA Vaccine Advisory Committee, I really think we would have voted no on that, given those data. Because the way that study was done was, you can get a fourth dose if you want. That's what it boiled down to. So people chose to get a fourth dose, or they didn't. Now, you would have to assume that those two groups were exactly the same in their healthcare seeking behavior, exactly the same in terms of their health backgrounds, their socioeconomic background. That's a big assumption, because you would argue that those who choose that fourth dose may be less likely to engage in risky behavior, more likely to be healthier. And so those data were thin, I think, at best. And again, what you care about here is immunological memory. There's two components to your immune system matters. One, neutralizing antibodies will stay elevated for 3 to 6 months and come down. That's what protects you against mild illness. Memory cells will protect you against severe illness for a much longer time. And because it's much actually easier to prevent serious illness than mild illness. It's easier to prevent serious illness because it takes longer to get a serious illness. And so all you need is memory cells. And so that's the question. And I just feel like we've crossed that fuzzy line from trying to protect against serious illness to trying to protect against all symptomatic illness. And this is a short incubation period, mucosal respiratory infection. If the entire world were vaccinated, you're still going to have this virus circulating and causing mild illness. And we're going to have to, at some level, get used to that.
Mm-hmm. The one thing I do hear is everybody's traveling now. Just look at the airport coverage, and people are traveling internationally, and many of these new variants seem to pop up internationally. And this is a hypothetical question that maybe there is no good data on. Is having higher neutralizing antibody levels more protective if you are somewhere outside of the United States and a new variant pops up?
Yeah, so it depends. If you've gotten the ancestral strain vaccine, you are not well protected against Omicron or the Omicron subvariants, period. And so the issue that's going to come up, I think, at the end of this month, on June 28th, we, the FDA Vaccine Advisory Committee, are going to be considering whether or not to give in the fall a vaccine that is a bivalent vaccine that contains both the ancestral strain and the Omicron strain. I mean, does that matter? Does that give you better protection against mild illness from Omicron or the Omicron subvariants as compared to just getting a boost with the ancestral strain? I'm not convinced that there is a critical difference here. And I know that our committee is sort of being pushed in a way of like saying yes to this, but the data that we've seen so far is not terribly convincing. I'm going to assume that we're going to get more data that's going to be more convincing than what we've seen so far.
Well, there are news reports that Moderna is working on an Omicron specific vaccine.
Oh, they've already had a press release.
That's right.
It was pretty inscrutable, but actually the press release, it's the press release right here. That's the press release. Yeah, they have a bivalent vaccine that they're working on, and hopefully the data are better than those.
All right. Okay. So we'll stay tuned for the meeting next week. Given that we've moved, or in the process of moving from pandemic to an endemic form of COVID, and more individuals are deciding not to wear masks. I mean, you yourself said you had a mild case a few weeks ago. Tony Fauci had COVID. How do people think about antigen testing? Because the list of symptoms is pretty much every symptom that you could possibly have. And we know that early on in the disease, your testing may be negative. So how do you think about antigen testing and just going to work, or going through your daily life?
Well, so anytime you have upper respiratory tract symptoms, the odds are it's caused by a virus, whether it's SARS-CoV-2 virus or influenza, parainfluenza, rhinovirus, et cetera. So it's probably a good idea, independent of whether you test, to wear a mask. And if you have to go to work, because some people do have to go to work, not all of us have the luxury of staying home, wear a mask if you're symptomatic. And when you're not symptomatic, then I think you don't have to wear a mask anymore. I know that there are people, even in hospitals, who don't test when they have upper respiratory symptoms because they figure they're wearing a mask anyway.
Right. Exactly.
What's the difference? So you make a really good point. I mean, the definition of pandemic is it changes the way that you live, work, or play. The definition of endemic is it doesn't. And certainly, I think in many areas it doesn't. I mean, right now I'm in Avalon, New Jersey. But when I'm in Philadelphia, a lot of people wear masks, even outside, and certainly inside when I shop in the grocery store, most people are wearing
Yeah.
masks.
Yeah.
So therefore, it is a pandemic in Philadelphia because everybody really, it changes the way you behave. In Avalon, New Jersey, no one wears a mask. You can go to the Acme here in Avalon, New Jersey, no one wears a mask. So it's endemic in Avalon, New Jersey. It's sort of what we decide it is in some ways.
Yeah. You mentioned Paxlovid early on. What are the indications for getting Paxlovid? Given that if you are vaccinated, many people have a mild disease, but you have this 5-day window, right, to get the Paxlovid. If you're over 65, say you're over 65, what should drive you to get Paxlovid?
The problem with Paxlovid is the study that was published in the New England Journal of Medicine, which found that if you took Paxlovid in the first few days of your illness, you decreased your chance of developing serious illness by about 90%. The problem with that study was done in unvaccinated people because that way the drug can look as good as possible. It would be interesting to see how much that matters in somebody who's already vaccinated. I mean, for me, when I had an illness that clearly was COVID and felt much better the second day, I had no interest in taking Paxlovid. I felt that my immune system, because I was vaccinated, was going to take care of this virus on its own, which is true. So it would be nice to have data for Paxlovid in people who are fully vaccinated. I mean, who've gotten, say, 3 doses of the vaccine. That would help. But I think certainly someone who is at high risk, someone who is elderly or has multiple comorbidities that really do put you at risk. You're immune compromised, you have, chronic lung disease or chronic heart disease. I mean, the kind of things that really do put you at risk. You could argue that that's a value there, but it would be nice to do the studies because you don't really have those studies.
Right. What about long COVID? I don't think anyone would argue that, 2 to 3 days of a mild upper respiratory infection, it's like what you deal with, right? It's life. But then there's this concern, if it's COVID, maybe then I have to deal with long COVID. What's the data now on the risk of long COVID from people that get these 2-day infections?
Right. So I think we need to better define long COVID. I think long COVID is more than one thing. And so if you look at these sort of the meta-analyses that go through long COVID, the one symptom that always rises to the top is fatigue, which is hard to characterize. And so it would be nice to have objective signs and symptoms that are measurable for long COVID. And then to do the kinds of studies, either the virological studies or the immunological studies or psychological studies to try and figure out who's at risk and therefore who really is most likely to benefit from, say, an additional dose of vaccine than those who are less at risk. I think it's a very vague subject, long COVID. It's also subject the kind of cottage industry of false hope that invariably comes up in situations where medicine hasn't really caught up to something yet. So there's a lot of alternative remedies that are sort of thrown at people with long COVID. I think it needs to be better defined. I think when you see it, it tends to be in people who are unvaccinated and have a severe illness. I mean, this virus is not your typical respiratory virus. What this virus does is it causes you to make essentially an autoimmune response, an immune response against your own blood vessels, against the endothelial cells that line your own blood vessels. That's MIS-C and MIS-A, which is to say this multi-system inflammatory disease of children or adults, where someone gets infected, essentially resolves their infection, and then a month later or so, 3 to 4 weeks later, has high fever and evidence of not just pneumonia, but liver disease, kidney disease, heart disease. That because this virus causes vasculitis. I don't know of any other respiratory virus that does that. So that's what makes this virus particularly scary. But if you're vaccinated and you have a mild illness, what's your chance of having long COVID? I imagine very small, and we need to identify that.
Mm-hmm. Speaking of liver disease, the severe liver disease that we're hearing reports about in children over the last month, 2 months, I'm beginning to hear some reports that is associated with COVID. They're putting it in this long COVID category. Is any of that confirmed, or is that just?
I've heard what you've heard. I mean,
Okay.
so adenovirus 41 was initially associated, but adenovirus 41, which is typically an intestinal pathogen causing intestinal disease, is fairly common. So it's hard to know whether that was in any sense contributory. People have now talked about this as being associated with the virus, with SARS-CoV-2. Certainly SARS-CoV-2 can be detected in feces. That's true. To what extent that means that this is in any sense associated with liver disease, I don't know. I mean, I still think the jury's out on what that is or whether it is an infectious disease. I think we'll see. What's interesting is that some children or some people who've had this have had to have liver transplants, which is to say you now have the liver. So you should be able to look to see whether there's viral particles, for example, by electron microscopy, to see whether there's any evidence of a virus there.
Yeah. Okay. All right. And finally, monkeypox. The World Health Organization is scheduled to meet today, and from reports will likely declare monkeypox an international public health emergency. currently more than 140 cases in the US. What does the average individual need to know about the current state of monkeypox? Given that we tend to hear, every new case that's confirmed in the United States, what do people need to know about monkeypox? What are the symptoms they have to worry about?
Monkeypox is an orthopox virus like smallpox. The good news, it is much, much less dangerous than smallpox was. But the rash of monkeypox does look like smallpox. It's interesting, if you look on the CDC's website, it says, like for the clinician, it says you can tell it's monkeypox because it looks like a fairly mild smallpox infection, like anybody's seen a mild
Oh,
smallpox these
that's
days.
right. Yeah.
But it can be fatal, but it's fatal maybe 1-2% of the time. So that's not typical. It is spread both by the respiratory route as well as by coming in contact with someone who has monkeypox, but you're not contagious unless you have symptoms. It's a pretty characteristic looking rash. You can see the rash on the website, but it doesn't look like smallpox, actually. It's just not smallpox. It's called monkeypox because in 1958, it was identified in 2 colonies of research monkeys, but it's really not a monkey virus. It's a rodent virus, so it should be called rodentpox. It was seen most commonly in Africa. Now it's obviously spread to other countries, and it also seen more commonly in men who had sex with men, and so there was a question about whether or not this was a sexually transmitted disease. If you look on the CDC's website now, it'll say that there hasn't been detected in bodily fluids like semen, but certainly any close physical contact with that lesion or those blisters will put you at risk of getting infected. But obviously it's not just that. Anybody can get this virus. We'll see. I mean, there's some good news with this. There is a drug, tecovirimat, which appears to be highly effective. The way that drug works is it affects the ability of the virus to leave the cell, affecting the envelope of that virus, which surrounds the virus, so it can't really leave the cell as easily. That's good. Also, the smallpox vaccine works. For those of us who were born before 1972 who got the smallpox vaccine, it's probably about 85% effective at preventing monkeypox. But we stopped giving the smallpox vaccine routinely in this country in 1972. So you have 50 years of people who are susceptible to this virus. If this gets worse, maybe the smallpox vaccine will come back. There are 2 forms of the smallpox vaccine. One is the live attenuated version of the vaccine. It used to be made by Wyeth called Dryvax. There's also this modified Vaccinia ankara strain, which reproduces itself much less well. So there's the kind you get by scarification, which is a little more dangerous of a vaccine. And then the kind you get as a shot, which reproduces itself much, much less well. That's a much safer vaccine, which would be, I think, if there were to be a vaccine that would come into more general use if this got worse, it would be that vaccine.
Okay. How do they make that decision on starting to vaccinate people again? Is it number of cases? Is it?
Yeah, I'm sure that's right. It's just
Yeah.
how common. I'm not sure exactly what that line is. I'm sure it's a fuzzy line, but we'll see. I mean, because we went through this once before. I mean, when I was on the advisory committee for immunization practices in the early 2000s, we were on the verge of invading Iraq, and the George W. Bush administration wanted to give this vaccine to everyone. To give the smallpox vaccine to everyone. This is before we had the modified Vaccinia ankara vaccine, the scarification vaccine, which had a difficult side effect profile, to put it generously. And they talked George W. Bush down off that vaccinating the general population. And so then it became an issue of vaccinating frontline responders, people who work in the emergency department, people who were emergency medical transport people. I actually voted against that. That didn't make sense to me. I mean, smallpox is like monkeypox. It's not that easily transmitted. I mean, you really do have to have sort of close contact, face-to-face contact. It's generally large droplet spread. There hadn't been a case of smallpox on the face of the earth since the 1970s, so it had been, decades of not having smallpox. And post-exposure vaccination does work for smallpox. So I argued against that, but I was the only one who voted against that. And it was a short-lived program. Maybe 40,000 people got vaccinated. But that vaccine virus can cause pericarditis, cause myocarditis, was associated with a couple of deaths. I think it was a bad idea. So I think you have to be careful with sort of a universal smallpox vaccine program, just because that so-called ACAM vaccine, the modified vaccine, your ankara vaccine, is much safer. I'd like to think if we're going to do it, it would be with that vaccine.
Okay. Any final thoughts on what do you think we should expect in the fall? Influenza, will be coming back, and there may be a new bivalent vaccine. What do you think we'll be seeing in the fall?
I think it'll be really interesting to see what happens fall and winter. I mean, if you look at the curves of cases and deaths, there's clearly an increase in the winter. This is clearly a winter virus at its heart. Now, we've had 2.5 years of this virus already. So you have a fairly high level of population immunity. I mean, 80 to 90% of people have antibodies in their bloodstream against this virus, either from vaccination or natural infection or both. You're seeing that essentially with these Omicron subvariants. You're seeing a lot of cases, but you're not seeing a concomitant increase in hospitalizations, a little increase, but not dramatic, and virtually no increase in deaths. I mean, you look, some days we have like 30 deaths. I mean, it's just really way, way down. That's because we have population immunity. So when winter comes, what's going to happen? Are we going to again see a dramatic increase in hospitalizations and deaths? I doubt it. I think we're going to see it come down yet off even last winter's peak. But we'll see. This will be educational. In terms of whether or not we offer a fallback vaccine, stay tuned. June 28th, we're going to be meeting. Moderna is going to have to prove, or Pfizer if they submit data. I haven't seen Pfizer's data. But what Moderna did was they did the study the right way, which is to say they took people who'd gotten 3 doses of a vaccine, with the ancestral strain, obviously, and then they gave them a 4th dose of this bivalent vaccine, which had the ancestral strain or the ancestral strain plus Omicron, not an Omicron subvariant, Omicron. And then they compared that to people who just got the ancestral strain. So that was the question. Did you get a better immune response to Omicron if you had that bivalent vaccine than if you just had the ancestral vaccine? Because remember, every time you give a dose of the ancestral vaccine, you do get a broadening of the immune response. That 3rd dose of vaccine does broaden your immune response against Omicron and the Omicron subvariant. So then the question is, if you give just the Omicron one for the boost, is that better than just giving the ancestral strain? And the answer was, it was better a little. I mean, it was like 1.7-fold better in terms of geometric mean titer of neutralizing antibodies. I think, at least the data we've seen so far, and we'll see how this plays out, that is, although a statistically significant difference, I doubt if that's a clinically significant difference. I certainly doubt it's going to be long lasting. I doubt if it has much of an impact on immunological memory. So is it really worth it to do this? And also, Omicron was the strain that was picked, and Omicron's gone. I mean, we're really dealing with BA2, BA4, BA5, and there's a much lesser neutralizing response against those subvariants as compared to Omicron. So when you're seeing a 1.7-fold increase with Omicron, what does that mean for BA4 and BA5? So it's hard to chase these variants. It's hard to catch this moving train, the SARS-CoV-2 virus. But I think if there's clear evidence that this makes a difference, great. But if there isn't, hopefully they'll put it to a vote. Hopefully they'll make us vote, make us commit ourselves.
Okay. Well, do you think we're going to get to, and this is my last question, promise, do you think we're going to get to the point like with influenza, where every year, there's a new vaccine based on what we're seeing? Will that happen with COVID at some point? Maybe not every year, but every other year or something like that?
Right. So I would argue that coronaviruses are not influenza virus. I mean, we get an influenza vaccine every year because even if you've been naturally infected or immunized the previous year, you're still at some risk for serious disease. For this virus to date, it looks like protection against serious disease is holding up. Now, that may not be true after a while. There may be a variant that arises, which is not only immune evasive for protection against mild disease, but immune evasive for protection against all disease, including serious disease. If that's true, then you're talking about the need for a variant-specific vaccine. But you have to be careful about this, because what happens is, as you continue to boost with the same virus, you imprint. The old term used to be original antigenic sin, so which makes you less capable of then responding to a new antigen. Probably the best, most recent example of that is the HPV vaccine. I mean, when Merck launched this HPV vaccine, human papillomavirus vaccine, there were 4 serotypes in that vaccine. 6, 11, 16, 18. When they then expanded that to include 5 more serotypes, to include more strains that were associated with cancer, what they found was that if you got 2 or 3 doses, depending on your age, of that HPV-9 vaccine, you had an excellent immune response to all 9 serotypes. If, however, you got HPV-4 first, you had a very good immune response to the 4 strains that were then in HPV-9, but not as good as those who'd never gotten HPV-4 against those other 5 strains. That's imprinting. And you have to be careful, because there is some evidence that that's already happening here. It really upsets me when public health officials say, there's no downside. There's always a downside. There's always downside. Anything that has an upside can have a downside. If it doesn't have a downside, it probably never had an upside.
All right. Well, Paul, thank you so much for taking the time to talk today. And thanks to all of you for listening. We'll be back again with another episode of College Conversations, Medicine, Science, and Society soon.